Imagine a shoulder so damaged, so weak, that just lifting your arm feels, well, like lifting a brick. It's not just a nagging ache, it's this profound loss of function. Stops you working, playing sport, even doing simple things day to day. So what happens when the usual fixes, the standard repairs, just aren't enough? Welcome back to the deep dive. We cut through the noise, bringing you the crucial insights from the latest research and expert thinking. Today, we're getting into a really significant challenge in orthopedics. The irreparable posterosuperior rotator cuff tear. We've got a stack of recent papers looking at this complex injury, and a fascinating surgical solution, the lower trapezius tendon transfer, or LTT. Our mission then is to unpack the thinking behind it, the techniques, the outcomes, really help you understand what matters in this evolving field. And guiding us through this is Professor Mo Imam, a leading expert whose work is right at the forefront of treating these complex shoulder problems. Professor, thanks so much for joining us.
Thank you. It's a pleasure to be here. It's a field that's seeing some really quite exciting advancements, actually, pushing the boundaries for patients with these, well, very difficult problems.
Absolutely. So let's jump straight in, maybe with a few quick questions just to set the scene. Firstly, when we talk about an irreparable rotator cuff tear, are we just talking about a really, really big tear? Or is there more to it?
That's a great place to start. Well, size is often a factor,
Right.
definitely. But irreparable goes beyond just the dimensions. It fundamentally means the tissue quality itself is too poor, or maybe the tear is pulled back too far retracted, or the muscle has degenerated too much. Essentially, you can't get a durable, tension-free repair back to where it's supposed to attach.
Got it. So it's really about the quality and the state of the tissue, not just the size of the hole.
Precisely. The biological environment, if you like.
Okay. Second question then. Traditionally, other tendon transfers have been used for large tears, haven't they? Like the latissimus dorsi transfer. Why isn't that always the ideal fix, especially for these posterior superior ones?
Right, the latissimus dorsi, or LD transfer. It's certainly a valid option, and it has helped many patients, no question, particularly with the pain relief. But its main job naturally is internal rotation, turning the arm inwards. When you transfer to try and restore external rotation, which is the key function lost in these posterosuperior tears, well, its biomechanical force vector, its line of pull, isn't quite ideal.
So it pulls in the wrong direction, essentially.
Not exactly the wrong direction, but it tends to give more of a vertical pull. What you really need for effective external rotation is more of a posterior and lateral pull, especially when the arm is close to the body, in adduction. The LD struggles to provide that specific rotational force effectively in that position.
Right, so you're asking a muscle to do a job it wasn't really designed for, and the mechanics aren't quite optimal.
That's a very good way of putting it. And that leads to, well, variable functional outcomes, especially when it comes to regaining strong external rotation. Pain relief might be good, but getting that outward turn back could be hit and miss.
Okay, that paints a clear picture of the problem and I suppose the limitations of that traditional approach. So final quick setup question. What's the basic biomechanical argument for why the lower trapezius might actually be a better choice for restoring that external rotation?
The core idea, and this is really backed up by the biomechanical studies we can talk about, is that the lower trapezius, the LT muscle, its natural line of pull, its vector, much more closely mimics the infraspinatus. That's one of the key muscles that's usually gone or badly damaged in these irreparable tears.
Ah, so it pulls more like the original muscle did.
Exactly. It provides a more suitable rotational moment. It gives you a better mechanical advantage for achieving that external rotation.
That sounds like a potentially powerful advantage. Let's dive deeper into that then. We've established what an irreparable tear means: significant damage, often supraspinatus and infraspinatus involved, retraction, maybe poor muscle quality. Can you expand a bit on the clinical impact? What does this actually look like for the patient day to day?
Yes, what's really crucial to grasp is the profound functional loss. It's not just pain, although pain is often there. It's significant weakness, an inability to actively lift the arm forwards, that's forward elevation, or rotate it outwards, external rotation.
So simple things become impossible.
Pretty much. Think about reaching for something just above shoulder height, or even turning a key in a lock, lifting a cup of tea away from your body. These all need active elevation and that controlled outward rotation. When the supraspinatus and infraspinatus are effectively gone, that ability is severely compromised. The sources we looked at consistently highlight this. It's a debilitating loss of active movement, impacting their work, their sport, even just managing personal care. It really does fundamentally alter their daily life.
It sounds like it's not just pain stopping them moving. The actual machinery for those specific movements is broken.
That's a good analogy. The engine for those movements is offline.
And you mentioned the limitations of the latissimus dorsi transfer. Let's really try and dissect why its biomechanics fall short for these particular tiers, drawing on what the research shows.
Certainly. So the LD transfer, whilst valuable, faces these inherent biomechanical hurdles when you ask it to restore external rotation. As I mentioned, its native job is internal rotation, pulling inwards, and adduction, pulling down towards the body. When it's transferred, it's usually routed around the back, posteriorly. But the key issue remains its line of pull. The research points out that after transfer, the LD creates a force vector that's predominantly vertical. It lifts, but doesn't rotate outwards effectively.
So it helps pull the arm up, maybe, but not turn it out.
In essence, yes. To restore active forward elevation and critically external rotation, especially with the arm down by the side or only slightly lifted, you need muscles that provide rotational leverage. A force that pulls or pushes to create rotation around the joint center. Think of the shoulder joint, the glenohumeral joint, almost like a ball balanced on a small tee. The rotator cuff muscles normally work together in pairs, force couples pulling in different directions but coordinated.
To keep it stable.
Yes, exactly. To stabilize the ball on the tee and produce smooth, controlled movement like rotation and lifting. The native supraspinatus and infraspinatus are key players in these force couples. The LD's primarily vertical pull struggles to replicate that essential rotational component effectively, especially for initiating external rotation or stabilizing the humeral head during the early phases of lifting the arm.
So the LD provides some lift, maybe some stability by covering the defect, but not that specific rotational control and stabilization needed, particularly when the arm is down low.
Precisely. And the sources reference studies using electromyography, EMG, which measures the electrical activity in muscles. These studies show there's actually quite limited EMG activity in the transferred LD when patients try to abduct or externally rotate their shoulder, especially in that crucial position with the arm by the side.
So the muscle isn't even firing properly for that movement.
Well, it's not being effectively recruited, or perhaps it's just not positioned biomechanically to generate the force and the moment, arm the leverage needed for external rotation in that context. So this electrophysiological evidence really supports the biomechanical analysis. It might help with pain, might provide some passive stability, but active functional recovery, especially getting that external rotation back, remains quite variable.
That really clarifies the mechanical mismatch, and that's precisely the gap the lower trapezius tendon transfer is trying to fill. So how do the LT's biomechanics differ? Why does the research suggest it's a more appealing candidate?
Right. The core biomechanical advantage of the lower trapezius lies in its inherent line of pull and its position relative to the shoulder joint's center when it's transferred. The LT muscle, it originates lower down on the spine, the thoracic spine, and attaches onto the scapula, the shoulder blade. Its natural job involves pulling the scapula down and in, helping stabilize it for overhead movements. Now, when you detach its insertion and transfer it to the humerus, its vector, its direction of pull, is more posterior and lateral compared to the LD.
Closer to the original external rotators.
Much closer. It mimics the line of action of the deficient infraspinatus and teres minors, those key external rotators, much more effectively. And the biomechanical studies cited in the papers provide quite compelling evidence for this. Research using cadaveric models and computer simulations has actually demonstrated that the LT transfer is more effective at restoring shoulder kinematics. That's how the bones move relative to each other and those critical glenohumeral force couples we talked about.
And especially with the arm by the side.
Particularly in the adducted position, yes, with the arm at the side. That's where it seems to have a distinct advantage in restoring stability and rotational potential.
So the research isn't just theory, it's actually showing a measurable difference in how the joint moves after the transfer.
Precisely. And the studies quantify this advantage. They use metrics like the external rotation moment, ARM, the ERM.
To leverage, basically.
Exactly. The ERMA is essentially the leverage the muscle has. It's the perpendicular distance from the joint's center of rotation to the muscle's line of action. A bigger ERMA means more rotational power. And the sources highlight that the LT transfer results in a significantly larger ERMA for external rotation, specifically with the arm at the side, compared to the LD transfer.
So it gives the muscle much better leverage to actually turn the arm outwards, which is exactly the function you're trying to restore.
That's the key. And what's particularly interesting is that the ERMA of the transferred LT in this position can be comparable to the native infraspinatus and teres minor.
So it really can potentially replace that lost function quite effectively.
Biomechanically, yes, it has that potential. The studies also looked into the best place to attach it. They found that attaching the transferred LT tendon right onto the original infraspinatus insertion site on the greater tuberosity of the humerus, the bony prominence on the upper arm bone, yields the greatest ERMA.
So it simulates the native setup best.
It seems to, yes. It gives the best simulation of native external rotation. So that specific surgical target where you fix the tendon is guided directly by this biomechanical evidence.
That level of detail, guided by the mechanics, is fascinating. Knowing precisely where to put it for the best effect.
It is. It really speaks to the precision involved in this type of surgery. But it's also important, for both surgeons and patients to have realistic expectations. Whilst LTT significantly improves the biomechanics and function, the sources are quite clear. Even with a successful transfer, the joint kinematics, the way the joint moves, and the reaction forces within the shoulder joint, they never completely normalize.
Right. It's not perfect.
No. You're improving a severely dysfunctional system, often dramatically, but you're not restoring it to perfect, pristine health. It's crucial to understand that limitation.
That's a really important point. Significant improvement, not a magic wand. You also mentioned earlier that the LT muscle's ability to be selectively activated is important. What does that actually mean in practice for a tendon transfer?
Right, selective activation means the patient can consciously learn to contract just the lower trapezius muscle, even after it's been surgically moved. Studies looking at voluntary contractions have shown this is possible. And it's vital because for the transfer to give active movement, not just passive support, the patient's brain needs to be able to find and fire that specific muscle in its new role.
So they have to relearn how to use it.
Exactly. It requires neuroplasticity, the brain's amazing ability to remap itself and learn new motor patterns.
Yeah.
The patient has to essentially re-educate that muscle, guided by physio, of course.
So the patient needs to be capable of that learning process. That ties back to the ideal patient profile, which I know we'll get to. It's interesting, though, this technique wasn't originally designed for rotator cuff tears at all, was it? It came from nerve injury cases.
Yes, that's a key part of its history. The whole concept of using the lower trapezius for a transfer was first described for restoring external rotation in patients with specific nerve damage. Things like traumatic brachial plexus injuries, or sometimes in children with obstetric brachial plexus injuries, where the nerves supplying the normal external rotator muscles were permanently damaged.
So the muscles themselves were okay, but the signal wasn't getting through.
Often, yes, or the muscles had wasted because of the nerve damage. Surgeons realized the LT had the right properties. It was expendable, meaning you could take it without causing a major new problem. It had enough length and could move sufficiently, and crucially, it had that suitable line of pull. So it could substitute for the lost external rotation function in those nerve injury cases. It was only more recently adapted and popularized as a solution for these massive, irreparable rotator cuff tears, which cause a very similar functional problem, that loss of external rotation, even though the root cause is different, tendon failure rather than nerve failure.
So applying a proven principle to a different but related problem.
Precisely. It's a great example of how surgical principles can be translated across different conditions when the functional deficit is similar.
That makes perfect sense. So given this is quite a sophisticated procedure with specific biomechanical aims, who is the right patient for a lower trapezius tendon transfer, patient selection must be absolutely critical.
Paramount. Yes, patient selection is absolutely key, and the sources are very clear on the criteria. Firstly, you must have confirmation of an irreparable posterosuperior rotator cuff tear. And as we said, that's not just about size on an MRI. It involves looking at how far the tendon has retracted, the quality of any remaining tendon tissue, and very importantly, the quality of the muscle itself. The sources highlight that tears involving both the supraspinatus and infraspinatus, often with significant fatty degeneration of those muscles, are the typical indications.
You mentioned fatty degeneration there. Can you just explain what that means and why it's so important in this context?
Yes. Fatty degeneration, or fatty infiltration, is where muscle tissue gets replaced by fat over time. This tends to happen when a muscle is detached from its tendon, chronically, and isn't working properly. We assess it using scales like the Goutallier classification, grading it from 0, which is no fat, up to 4, where there's more fat than actual muscle visible on the scan. The sources indicate that if the native infraspinatus muscle, for example, has Goutallier grade 3 or 4 changes, a standard repair is highly unlikely to work well. There just isn't enough healthy, functioning muscle left.
So that helps define it as irreparable.
Exactly. It's part of classifying the tear as irreparable and assessing the overall state of the shoulder. For LTT, the quality of the remaining muscles, like the deltoid and subscapularis and the LT itself, are also key. But the state of the original torn muscles informs the decision that a standard repair isn't feasible. Secondly, and this is perhaps equally crucial, the patient must have minimal glenohumeral arthritis.
Wear and tear in the main joint.
Precisely. Wear and tear in the main ball and socket joint. The sources specify ideally Hamada grade 1 or less. Hamada grading is a way we classify arthritis on x-rays specifically in the context of rotator cuff problems. Grade 1 is very mild changes, whereas grade 5 is severe arthritis with significant bone changes. If there's significant arthritis, say Hamada grade 2 or higher, certainly 3 or 4, the fundamental problem isn't just the missing cuff tendons anymore. The joint surfaces themselves are worn out.
So the transfer wouldn't work properly?
Trying to improve function with a tendon transfer when the underlying joint is arthritic? Well, it's like putting a new engine in a car with square wheels, as the saying goes. The basic mechanics of smooth movement are already compromised by the joint surface damage.
Right, you need a reasonably healthy joint surface for the transfer to work effectively again. So that makes complete sense. Okay, so beyond the tear itself and the arthritis level, what else defines the ideal candidate? What sort of person typically gets offered this?
Well, typically, patients present with that persistent pain and the significant functional limitations, the inability to actively lift or externally rotate the arm that we discussed. And the sources also point towards the patient profile. LTT is often indicated for younger and more active individuals.
As opposed to something like a shoulder replacement.
Exactly. This contrasts with options like reverse shoulder arthroplasty, which is often a better choice for older, less active patients, especially if they do have significant arthritis at Hamada grade 2 or higher. The younger, more active patient generally has greater demands, needs to regain significant function, and often has better capacity for the rigorous rehabilitation needed, and potentially better neuroplasticity to learn to use the transferred muscle effectively. They need to be motivated.
Motivation sounds key.
It really is. Other important factors include having a supple shoulder joint beforehand, meaning it doesn't have significant stiffness or fixed contractures preoperatively. Trying to restore active motion with the transfer when the joint is already very stiff passively is much more challenging.
That paints a clear picture of who might be a good fit. What about the other side? Who is definitely not a candidate? What are the absolute non-starters?
Right, the absolute contraindications are pretty clear-cut. Firstly, any active soft tissue infection in or around the shoulder. You simply can't do elective surgery in an infected area. Secondly, paralysis of the trapezius muscle itself. The transfer relies entirely on the LT being a working, functional muscle that can be re-educated. If it's paralyzed, the procedure is impossible.
Makes sense.
And thirdly, as we discussed, advanced glenohumeral arthritis, often considered Hamada grade 2 or higher by some surgeons as a relative contraindication, but certainly grade 3 or 4 is an absolute contraindication for this specific procedure. A reverse replacement would likely be considered then.
So infection, a non-working trapezius, or significant joint wear rules it out completely. What about things that might make surgeons pause, the relative contraindications?
Yes, relative contraindications often involve the condition of the other key shoulder muscles. The state of the subscapularis muscle, for instance, which sits at the front of the shoulder.
What does that one do?
It's a key internal rotator and provides crucial stability at the front of the joint. Ideally, you want an intact or at least reparable subscapularis. While the LTT helps restore posterior stability and external rotation, the subscapularis provides the essential counterbalance at the front. If the subscapularis is also severely deficient and irreparable, alongside the posterior superior tear, outcomes can be less predictable. It makes the whole shoulder more unstable.
Okay, so the front needs to be holding up too.
Pretty much. Similarly, the deltoid muscle must be functional. The deltoid, that big muscle covering the shoulder, is the prime mover for lifting the arm away from the body abduction and gross elevation. The LTT helps restore external rotation and contributes to the dynamic stability needed for smooth elevation. But you absolutely need a working deltoid to achieve a good range of forward flexion and abduction overall. If the deltoid is severely compromised, maybe from previous surgery or nerve injury like an axillary nerve palsy, the patient won't get satisfactory lifting ability back, even if the LTT successfully restores external rotation.
So you really need the rest of the shoulder's team, the joint surface, the subscapularis, the deltoid, to be in reasonably good shape for the LT transfer to have the best chance.
That's a very good summary.
Yeah.
An advanced stage, as you mentioned, is often considered a relative contraindication,
Why is that? Just recovery.
primarily because of potentially reduced capacity for the very demanding rehabilitation and perhaps slightly less neuroplasticity compared to younger patients. Though, it's important to say, age itself isn't a strict cutoff. Physiological age, overall health, activity level, and motivation are often more relevant than just the chronological number.
Right, it's the individual, not just the birth date.
Exactly.
That's a really comprehensive view of patient selection. Now let's turn to the surgery itself. The sources describe different ways of doing it: open, mini-open, and this arthroscopic assisted technique. Could you walk us through the general steps and maybe highlight the nuances, particularly of that less invasive arthroscopic approach?
Certainly. So the procedure itself is typically done under general anesthesia. The patient is usually positioned either sitting up in a beach chair position or lying on their side, lateral decubitus. The arm is usually secured in an arm holder. It's quite a complex operation, generally taking around, say, 1 to 2 hours, maybe a bit longer depending on the specifics, and it's often managed as an outpatient procedure these days in suitable patients and settings. Now, a really critical aspect, which the sources consistently highlight, is the frequent need for a biological graft to lengthen the lower trapezius tendon.
Why is that needed? Isn't the LT tendon long enough?
Often not, especially in these massive chronic tears where things have been retracted for a long time. The native LT tendon simply doesn't have enough natural length or excursion. That's the distance it can naturally travel when the muscle contracts to reach its new attachment point on the humerus without being under excessive tension.
So you can't just stretch it further. You actually have to add a piece in the middle.
Precisely. You need to bridge the gap. Achilles tendon allograft, that's tendon tissue from a human donor, is very commonly used for this. It's strong, readily available, and comes in suitable lengths. Semitendinosus autograft, taken from the patient's own hamstring tendons, is another possibility, although some sources suggest it might be slightly less robust than Achilles.
Does using a graft add risks?
Well, yes. Using any graft introduces potential factors. There's the integration of the graft, the healing process at both ends, and theoretically there's a risk of creep, the graft slowly stretching out over time.
Would that make the transfer less effective?
Potentially, yes. If it stretches significantly, it could reduce the resting tension, maybe affect the long-term function. Though the clinical significance of creep, specifically in LTT outcomes, is still something being studied. It doesn't seem to be a major cause of outright failure, but subtle effects are possible.
Okay, that's an important consideration. So how is the lower trapezius tendon actually harvested during the surgery?
There are two main approaches described in the literature. One is the indirect or medial approach. This involves a vertical incision, usually about 2 centimeters medial to the inner border of the scapula, the shoulder blade. The surgeon finds the muscle belly first and then carefully traces it down to where the tendon inserts onto the scapular spine. Now, a crucial anatomical point with this approach, and the sources really stress this, is the proximity of the spinal accessory nerve.
The nerve that makes the muscle work.
Exactly. It's vital because it innervates the entire trapezius muscle. It typically runs on the undersurface of the trapezius. And studies cited show its location can be variable, but it's often around that 2 centimeter medial mark, and potentially can be extremely close, even within 23 millimeters or so, to the actual tendon insertion point in some people.
Wow, that's incredibly close. So surgeons have to be extremely careful not to damage it during the harvest.
Absolutely paramount. Meticulous dissection is essential. Dissecting too far medially clearly increases the risk, but even working towards the tendon insertion requires great care to identify and protect that nerve. It's a non-negotiable part of this approach. The alternative is the direct or horizontal approach. This involves making an incision directly over the tendinous insertion on the scapular spine, usually running parallel to the spine itself.
And is that safer for the nerve?
Generally, yes. The sources indicate this approach is associated with less risk to the spinal accessory nerve because the dissection stays more lateral, closer to the bone of the scapular spine, and typically further away from the usual path of the nerve, which runs more medially.
Okay, so the direct approach seems preferable from a nerve safety perspective. Once the tendon piece is harvested, how is it prepared?
Whichever approach is used, the harvested LT tendon end is prepared with strong, non-absorbable sutures, often using a specific stitching pattern like the crack-out technique. This creates strong loops of suture at the end, which allows for secure handling and later attachment. Similarly, if an Achilles allograft is used, the bone block is removed, and the thick tendinous end, the part that will attach to the humerus, is prepared with similar strong Krakow sutures. The graft might also be marked or tagged to help keep it correctly oriented during the later steps.
Right. Let's focus then on the arthroscopic assisted technique, as it's described as less invasive. How does the graft actually get passed and attached inside the shoulder using cameras and small incisions?
Okay, so the arthroscopic assisted technique usually pairs with the direct approach for harvesting the tendon. The surgery starts with a diagnostic arthroscopy camera in the joint through keyhole incisions. This lets the surgeon have a good look around, confirm the tear is truly irreparable, check the joint surface, and deal with any other issues, like maybe trimming a frayed biceps tendon. Then, the crucial site on the humerus, the greater tuberosity footprint, where the original cuff tendon's attached, is prepared arthroscopically. This means using small shavers or burrs to debride the surface, cleaning it down to healthy, bleeding bone to create a good bed for the graft to heal onto.
Preparing the landing zone, essentially.
Exactly. Then, a really key technical step is creating a large enough opening in the infraspinatus fascia. That's the tough layer covering the infraspinatus muscle, usually through the posterior incision site used for the harvest. This opening needs to be generous enough to allow the graft, which is quite bulky, especially if it's Achilles, to pass smoothly, and without getting caught or kinked as it goes into the subacromial space. That's the space above the joint where the transfer needs to sit and function.
So making sure there's a clear, wide pathway for the graft is critical.
Absolutely critical.
Yeah.
Then comes the passage itself. This definitely requires skilled arthroscopic technique. Instruments like large graspers or sometimes a system using switching sticks and cannulas are introduced through the standard arthroscopy portals. Usually an anterolateral portal needs to be made large enough to let the graft pass through. These instruments are used to reach back to the harvest site, grab the sutures on the end of the graft, and carefully pull the graft through that prepared opening in the fascia, bringing it into the subacromial space, positioned over the prepared footprint on the humerus.
And avoiding twisting it.
Yes. Ensuring the graft doesn't twist during passage is vital. You want it to lie flat and maintain its intended line of pull.
That sounds like quite a delicate maneuver, doing that through keyholes.
It certainly is. It underscores why this technique has a definite learning curve. Once the graft is correctly positioned, its thick sutured end is attached down to that prepared footprint on the greater tuberosity. We use suture anchors for this small implants that screw or tap into the bone with strong sutures attached. Often, a double row technique is used with 2 rows of anchors to get a broader, stronger fixation of the graft onto the bone. The quality of the patient's bone in that area can influence the choice sometimes if the bone is soft. Different types of anchors or even techniques like using a cortical button might be needed for secure fixation.
And getting the tension right must be crucial here.
Absolutely paramount. Correct tensioning is key for the transfer to work optimally. This is achieved by holding the arm in specific degrees of abduction, lifting away from the body, and external rotation whilst the graft is being secured to the humerus. The sources often mention positioning the arm at around, say, 45 degrees of abduction and 45 degrees of external rotation when securing the graft to the humerus in the arthroscopic assisted procedure. This aims to set the right resting length and tension.
Getting that tension just right sounds like a real Goldilocks situation. Not too tight, not too loose.
It absolutely is. Too loose, and it won't function effectively. Too tight, and it might restrict motion or put excessive stress on the fixation. It requires careful judgment. The final step, then, is attaching the other end of the graft, the thinner end, to the patient's native lower trapezius tendon, which was harvested earlier. This is usually done using strong sutures again, often with techniques like a pulver-taft weave, which interlaces the tendons, or side-to-side Krakow sutures, to create a secure connection between the graft and the native tendon. And this connection is typically tensioned and tied with the arm positioned to achieve maximal tension on the whole transfer construct, often in maximal external rotation, with the arm at 0 degrees of abduction, or even slight extension.
And I imagine checking that nerve again is important here.
Absolutely. Before tying those final knots connecting the graft to the native LT tendon, the sources reiterate that a final check must be done to ensure the spinal accessory nerve is well clear, not being impinged or stretched by the transfer or the surrounding tissues. If there's any concern, a small piece of the medial scapular spine, where the LT originally attached, might need to be carefully removed, resected, to give the nerve more space.
It's clear this is a highly technical procedure with really critical steps at each stage. How do these different approaches, the full open, the mini open, and this arthroscopic assisted one, really stack up? What are the main pros and cons?
Okay, so the traditional open approach often involves what's called an acromial osteotomy, where a piece of the acromion bone, the tip of the shoulder blade, is surgically cut and later fixed back on, usually with screws. This gives the surgeon excellent, wide-open exposure for harvesting the tendon and attaching it to the humerus. However, it carries specific risks, like that piece of bone failing to heal back properly in non-union or problems with reattaching the deltoid muscle, which has to be detached quite significantly to get that exposure.
Does non-union cause problems?
It can, but interestingly, some studies mentioned in the sources found surprisingly comparable clinical outcomes, even when a bony non-union occurred. It suggests that sometimes a strong fibrous union might be sufficient, but it's still a potential complication of that approach. The mini-open approach tries to avoid the acromial osteotomy, reducing that specific risk, but it still involves splitting or detaching part of the deltoid muscle and generally offers more limited exposure compared to the full open technique.
Right. And the arthroscopic assisted.
The arthroscopic assisted technique, as we focused on, is highlighted primarily for being minimally invasive. It completely avoids the acromial osteotomy and significantly reduces any detachment of the deltoid muscle, often just splitting the muscle fibers rather than detaching the origin. And the sources link this to several potential benefits. Potentially less postoperative pain, possibly lower infection rates, maybe a quicker initial recovery phase, and minimal scarring.
And preserving the deltoid is a big deal.
Potentially, yes. Minimizing disruption to the deltoid could, in theory, lead to better long-term strength and range of motion.
Those benefits of the arthroscopic approach sound very appealing from a patient's perspective.
They certainly do, particularly preserving the deltoid attachment. However, as we noted, it absolutely requires specific, advanced arthroscopic skills and definitely has a learning curve for the surgeon. Another significant advantage of the arthroscopic approach, though, which shouldn't be overlooked, is the ability to simultaneously address other problems inside the joint, like tightening up a partial subscapularis tear or dealing with biceps tendon issues, all arthroscopically during the same procedure. That's often less straightforward with the open techniques.
So it sounds like a trade-off between invasiveness, the amount of exposure the surgeon gets, potential complications specific to each technique, and of course the surgeon's own expertise and experience.
That's a very accurate summary.
Okay, so once the surgery itself is complete, the journey is far from over. Rehabilitation is obviously critical. What does a typical rehab protocol or physio plan look like after an LTT?
Yes, rehabilitation is absolutely fundamental to getting a good outcome. It's not optional, it's integral. The sources outline a pretty structured multi-phase protocol, and sticking to it is key. Phase I is usually the first 6 weeks or so. This is all about maximal protection, allowing that initial healing to occur. The shoulder is immobilized in a brace, and importantly, it's often positioned in a specific amount of abduction and external rotation, maybe 30 degrees of abduction, and anywhere from 30 up to perhaps 70 degrees of external rotation. The exact position can vary a bit based on surgeon preference and the tension felt during the repair.
And that specific positioning, that's designed to take all the tension off the repair site.
Precisely. It minimizes stress on the healing graft to bone fixation and the tendon to tendon junction, just protecting everything whilst it knits together. During this phase, pain control is important, often using cold therapy. Patients start some very early, gentle, passive range of motion exercises, usually guided by the physio, perhaps starting around week 3. That's just to prevent stiffness, but critically, there's no active contraction of the transferred muscle allowed yet.
Just keeping things moving gently.
Exactly. And doing exercises for the elbow, wrist, and hand is important too to keep the rest of the limb mobile. Phase 2 then typically runs from about 6 weeks up to 12 weeks. This is where the transition to active range of motion happens. Patients gradually progress from active assisted exercises, where they might use their other arm or a stick to help move the operated arm towards full active range of motion, initially perhaps lying down, then against gravity. Weaning off the immobilization brace usually happens during this phase as well. And the sources note that patients often see quite significant visible improvements in their shoulder movement during this period as they start to carefully recruit that transferred muscle.
Do they have to avoid certain movements?
Yes, often exercises involving bringing the arm across the body, cross-body adduction, are restricted initially, as that can put stress on the posterior transfer site.
Okay, so starting to actively use the shoulder again, but very much under careful guidance.
Exactly. Then phase 3 begins around the 12-week mark, maybe a bit later, and the focus shifts squarely onto strengthening. This usually starts with isometric exercises, contracting the muscles without actually moving the joint, targeting the key shoulder stabilizers, the parascapular muscles around the shoulder blade, the deltoid, and any remaining healthy rotator cuff. Then, this progresses to isotonic strengthening, using resistance like therapy bands or lightweights. This typically starts maybe around 4 months post-op, with a very gradual increase in the load and intensity over time.
And when can people expect to get back to normal activities?
Well, return to lighter work duties or modified recreational activities is often permitted around the 6-month mark. But it's a gradual progression back to more demanding tasks or sports over the following months. Formal physiotherapy can often continue for up to a year, really, to fully optimize strength, endurance, and those functional movement patterns as the brain continues to learn how to best use the transferred muscle. It's definitely a long road, but a necessary one.
It certainly sounds like a significant commitment to recovery from the patient's side. What kind of results are actually being reported in the studies for patients who go through all this? Are those functional improvements really happening?
Yes, the clinical results reported in the literature are generally very encouraging, especially, as we keep saying, in carefully selected patients. Studies consistently show significant improvements in both pain levels, often measured using things like a visual analog scale, or VAS, and also in functional outcome scores. Common ones are the American Shoulder and Elbow Surgeon score, the AC score, or the ADLR score. Patients report substantially less pain and a much better ability to do their daily activities.
That's great. And crucially, what about the movement? Are they getting that lift and rotation back?
Yes, and this is where the procedure really validates its biomechanical rationale. The sources cite data showing really substantial average increases in active range of motion. Active forward flexion, lifting the arm forwards and up, often improves significantly. Maybe from around 100 degrees before surgery up towards 140 degrees, sometimes even more afterwards. Active abduction, lifting out to the side, sees similar gains, often increasing from perhaps 70 degrees pre-op to well over 130 degrees post-op on average.
Those are really big improvements in just the ability to lift the arm. And what about that key deficit you mentioned, the external rotation?
That's where the LT transfer often really demonstrates its value compared to, say, an LD transfer. Active external rotation, which is often severely limited beforehand, maybe only 10 or 20 degrees out from neutral, typically improves significantly, often to 30, 40 degrees, sometimes even more, after the surgery. The sources frequently highlight the conversion of a positive external rotation lag sign. That's an objective clinical test showing the inability to hold the arm in external rotation converting to negative after LTT. That's a clear demonstration of restoring active control over that specific movement.
Turning an objective sign of dysfunction into a sign of functional recovery that really is a powerful outcome. What about getting back to work or other activities?
Studies report quite a high rate of return to work, with figures around 67% mentioned in the materials we looked at. Remember, this procedure is often aimed at active individuals, so restoring their ability to return to their job, even if modified initially, is a really key measure of success. And what's also quite noteworthy is that LTT has shown good effectiveness even in more complex situations. For example, when there's a tear of the subscapularis at the front as well as the posterosuperior tear, although outcomes can be a bit more variable in those multi-tendon injuries. It's also shown promising results as a salvage option for patients who've had previous rotator cuff repairs that have failed. When less complex procedures haven't worked, LTT can still offer a viable route to improvement.
That makes it a really valuable tool in the surgeon's toolkit for those very challenging situations. It sounds like patient satisfaction reflects this. Is it generally high?
Yes, generally high patient satisfaction rates are reported. Some of the series looking specifically at the arthroscopic technique mention satisfaction levels around 90%, even when including those complex revision cases. It suggests that despite the complexity of the surgery and the undeniably long rehab commitment, patients generally perceive a very significant benefit in terms of pain relief and improved function.
We touched on the comparison to the latissimus dorsi transfer earlier based on the biomechanics. Are there clinical studies directly comparing the actual outcomes of LTT versus LD transfer side by side?
Yes, there are comparative studies emerging. The source materials mention one study by Bakes and colleagues, which actually compared LTT with a lower deltoid transfer, or LDT, which is another transfer option sometimes considered. While studies like that show both procedures can offer significant functional improvements compared to the preoperative state, they help position LTT relative to other techniques. The consistent clinical findings of significant improvement in external rotation with LTT do seem to strongly support the theoretical biomechanical advantages we discussed earlier compared to the known limitations of LD for rotation. Well, we probably still need more large-scale, head-to-head randomized trials directly comparing LTT and LD transfer, particularly the arthroscopic versions. The current evidence suggests LTT is a very strong contender, especially when restoring active external rotation is the primary goal.
It seems the clinical results are starting to align quite nicely with those biomechanical predictions, which must be reassuring. Looking ahead then, what are the lingering questions, maybe controversies, or areas where more research is still needed regarding LTT?
Well, whilst it's promising, there are definitely areas still under investigation and discussion. That potential for graft stretching or creep over the very long term is, as I mentioned, a theoretical concern. If the graft were to elongate significantly over many years, could it reduce the effective tension in the transfer and lead to some late decline in function? Some sources mention this hasn't been a major cause of actual fixation failure in their experience, but the subtle, long-term clinical implications of gradual graft elongation probably need more study.
Okay, so long-term durability of the graft is one area. What else?
Another key area is really pinning down the long-term outcomes of the newer arthroscopic-assisted technique compared directly against the more established open approaches. While the arthroscopic method clearly offers benefits like less invasiveness and potentially faster initial recovery, we really need more robust long-term clinical data. Ideally from randomized controlled trials comparing things like retear or failure rates, sustained functional improvement, and complication rates over, say, 5 or 10 years or more.
Comparing it to open LTT and maybe other transfers too?
Exactly. Comparing it rigorously against open LCT and also against other modern transfer techniques like arthroscopic-assisted LD transfer. Plus, that learning curve associated with the arthroscopic technique means outcomes might vary more depending on surgeon experience, especially initially.
So while the minimally invasive approach is very appealing, the full long-term picture and how it stacks up definitively against other options still needs to be completely mapped out with more high-quality research.
Precisely. It's still an evolving field in that respect. That being said, the success we have seen with LTT so far is attributed, in large part, to the fact that it adheres well to those fundamental principles of tendon transfer surgery.
Which are?
Selecting a muscle that is expendable, its removal doesn't cause a major new functional problem, ensuring it has similar excursion or travel and can be tensioned appropriately. And crucially, that it has a similar line of pull to the muscle it's replacing, allowing it to perform the desired function. LTT seems to score well on these key principles for restoring external rotation.
That adherence to the basic principles provides a solid foundation for the procedure, doesn't it?
It certainly does.
This has been a remarkably detailed look at quite a complex solution for a very difficult clinical problem. Professor Imam, as we start to wrap up this deep dive, what would you say are the 3 to 5 key takeaways you'd hope listeners will carry with them from our discussion?
Okay, I think I'd summarize the crucial points like this. First, irreparable posterior superior rotator cuff tears are a cause of severe functional loss, and LTT is a really valuable surgical option, but for a specific group, active patients without significant underlying arthritis in the joint. Second, the biomechanics matter. LTT offers a significant advantage over traditional transfers like the latissimus dorsi, specifically for restoring active external rotation, which is so often the key deficit. Third, patient selection is absolutely non-negotiable. You have to look carefully at the tear characteristics, the arthritis severity, think hemotic grade, the muscle quality, Goutallier grade, and the patient's activity level and expectations. Getting this right is essential for success. Fourth, the surgical techniques are evolving. Arthroscopic-assisted LTT is less invasive, potentially speeds up early recovery, but it nearly always requires that graft augmentation, and we still need more long-term data to definitively compare it to other methods. And finally, fifth, the surgery is only half the battle. A structured, committed, multi-phase rehabilitation program, the physio, is absolutely fundamental to achieving those significant improvements in pain, movement, and function that we see after LTT.
Those are incredibly clear and very actionable takeaways. Thank you. It's really fascinating to see how surgical innovation is tackling these complex shoulder problems. And as techniques like this arthroscopic-assisted lower trapezius tendon transfer continue to evolve, pushing the boundaries of what we can do, it does raise a compelling question, doesn't it? How do we ensure equitable access to these highly specialized procedures? And perhaps more fundamentally, how do we strike that right balance between the undeniable appeal of minimal invasiveness and the ongoing critical need for robust long-term clinical data to prove sustained effectiveness? Definitely a lot to consider there. If you found this deep dive insightful, please do take a moment to rate and share it with a colleague. It genuinely helps us reach more professionals like you. Professor Mo Imam, thank you so much again for sharing your expertise and guiding us so clearly through the nuances of the lower trapezius tendon transfer today.
It was my pleasure entirely. Thank you for having me on the show.
And thank you for joining us for this deep dive. We hope you feel a little more well-informed on this important topic in orthopedics. Until next time.